Hello, welcome to the NIH Stroke Scale Training. This is Heather Hedrick and I am the Staff Development Specialist for 4 West and Critical Care. In this video, we're going to talk about core measures for both ischemic and hemorrhagic stroke. We will talk about what counts for certain measures. We will talk about patient education, why it's so important, and what topics should be included. We will also hit the hot topics in the dysphagia screening and monitoring the NIH stroke scale. How often? In this video, we will watch the instructions for the NIH stroke scale. They're going to go through each element of the stroke scale in depth and cover what normal is, what abnormal is, and they actually will demonstrate patients that are abnormal. Then you're going to watch experts give tips on the stroke scale, and then they're going to talk about why the stroke scale is so important. The last thing is you will see a patient. You are to score the patient using the NIH stroke scale and then turn it into your educator. If you're 4 West or Critical Care, that would be me. Here are the core measures for ischemic stroke. VTE prophylaxis, discharged on antithrombotic therapy, anticoagulation therapy for atrial fibrillation or flutter, thrombolytic therapy, antithrombotic therapy by end of hospital day 2, discharged on a statin medication, stroke education, and assessed for rehab. So why do we care about these guidelines? Well, we care about, or not guidelines, but these core measures. One, because these are evidence-based. 2, this is something that comes from a long line of evidence from the American Heart Association, or more specifically the American Stroke Association, and it's what's best for our patients who have had strokes. So, core measures for hemorrhagic stroke, not much different than your ischemic stroke. You have your VTE prophylaxis, again, stroke education, and assessed for rehab. Speaking of core measures, so your VTE prophylaxis, here's a list of things that count. Low dose unfractionated heparin, low molecular weight heparins such as Lovenox, your SCDs or intermittent pneumatic compression devices, factor XA inhibitor, Coumadin or warfarin, venous foot pumps, oral factor XA inhibitors such as Arixtra, Xarelto, Eliquis, and Pradaxa. Here's the list of the medications that count for antithrombotic therapy. I won't read all these to you, but again, there's your Eliquis, Xarelto, Arixtra, Pradaxa, Plavix, Lovenox, Coumadin, aspirin. Aspirin is a big one. Aspirin seems to be good for everything. So these are your medications that will count for that patient discharged on antithrombotic therapy, patient received antithrombotic therapy at the end of day 2. Stroke education. Why is it important and what do we teach our patients and family? Patients who've had a stroke are at greater risk to have a recurrent stroke, so it's extremely important that they know what the risk factors are, that they know how to activate EMS. They understand the medications they're taking and the importance of these medications. They also need to know the signs and symptoms of the stroke, so if they do have a recurrent stroke, they know to call 911. And the importance of following up with their primary doctor or with their neurologist after discharge. Avoidable risk factors are risk factors that they can make better or that they can change, such as high blood pressure, smoking, high cholesterol, inactivity, obesity, diabetes, atrial fibrillation, by taking their blood thinning medications as prescribed, carotid artery stenosis, and excessive alcohol consumption. Risk factors that they can't really change: increasing age, gender, being a man, race, family medical history, or history of a previous heart attack or stroke. So they need to also understand their medications, like why are they taking an antithrombotic medication, and the importance of taking it, cholesterol lowering medications such as statins, Zocor, Pravachol, Crestor, these kinds of medications. And we do actually have a book, Understanding Stroke, What Can I Expect, that we can use to teach our patients and family, and that should be handed out to every patient who has had a stroke. Okay, so the dysphagia screening should be performed and documented before anything oral. Any oral intake, such as pills or water, fluids, oral CT contrast, anything. They should have it performed and documented in the ICU before they do anything. In 4 West, 5 Central, wherever these patients are admitted to, they must have it done. Even if the dysphagia screening was done in the ER, we should do another one before we give them anything by mouth. If they fail one item on the dysphagia screening, they fail everything. You don't have to go any further. And good technique is having the head of bed elevated at least 60 degrees and making sure their mouth is moist and clean, and monitoring their O2 saturation during the test. Our dysphagia screening is an evidence-based screen, so it's very important that we do this with each and every patient that's having a stroke. If you have a patient who has had TPA, the NIHSS stroke scale should be done every 15 minutes for the first 2 hours. When getting a report from the emergency room, we need to make sure that we know when the TPA was started and when it was finished. The complete stroke scale should be done every 12 hours. The most appropriate time to do this is at shift change with 2 nurses at the bedside. More monitoring guidelines for your stroke scale. TPA versus non-TPA. Items 1, 5, and 6, which are level of consciousness, arm, and legs. For the TPA treated patient, you should do the NIH items 1, 5, and 6 every hour for 24 hours. And then you can go to every 4 hours once that 24 hours is up. So again, it's important to know when the TPA was started and when it was completed. Non-TPA treated patients should be done every hour for 4 hours, then every 4 hours. This needs to be documented, and until the order is put in that this be discontinued, I don't know why they would discontinue it, whether they're here 2 days, whether they're here 20, we should be documenting a stroke scale and a complete stroke scale every 12 hours once a shift. Where is the stroke scale charted in Quest? Well, you're going to go to your flow sheets, then go to knowledge-based charting, find the assessments and interventions, then go to cognitive perceptual neuro, and under that is the NIH stroke scale. Okay, so that is it for the little helpful tidbits. Some instructions. You're going to watch the video. The first part of the video instructs you on the stroke scale. Like I said, it goes through it element by element. And at the end of the video, you will see a patient. Please score the patient, and then turn your NIH stroke scale sheet into your educator, and if you're for West in critical care, that would be me.
Administer the scale items in their exact order. Avoid coaching the patient, even though this may be counter to usual clinical practice of trying to elicit the best performance. Accept the patient's first effort. Score only what the patient does, not what you think they can do. During the course of testing, you may develop an impression of level of function or lesion. Those impressions must not influence your scoring. Again, score only observed performance. Sometimes these rules don't make sense, but if all examiners do the scale the same way, the scores will be consistent. Be sure to include all deficits in your scoring, including those deficits that may result from previous strokes. Not all decisions are simple. When you're having trouble deciding on a score, try ruling out the extreme score and then weigh the mid-scale scores. You should keep the stroke scale reference material, such as the scoring guide, nearby when you administer and score the NIH stroke scale. However, at the bedside in a critical situation, all you need is the proper scoring sheet, the naming sheets, and a pin. These are the overall conventions. Now let's focus on each item of the scale. I will describe and perform each item of the scale for you and then go over scoring. Item 1A is the examiner's overall impression of patient alertness. Normally, you'll get enough information when taking the patient's history to make this assessment. Ask the patient 2 or 3 questions about the circumstances of the admission. Stimulate the patient by patting or tapping the patient, or on occasion, more noxious stimuli such as pinching may be needed to check the level of consciousness. Good morning.
Good morning.
Are you having any pain today?
Little pain.
Little pain? Are you comfortable now?
No, yes.
Okay.
For scale item 1A, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if the patient is alert and keenly responsive. Score a 1 when the patient is not alert but can be aroused with minor verbal stimulation. Score a 2 for the patient who is not alert and requires repeated stimulation to attend, or who requires strong, painful, or noxious stimulation to make movements. Score a 3 if the patient makes only reflexive posturing movements in response to repeated painful stimuli. A patient with a 3 on this scale item is generally considered to be in a coma. A patient suspected to be in a coma should be stimulated by rubbing on the chest or by using a painful stimulus. A 3 is scored only if the patient makes no movement other than reflexive posturing in response to noxious stimulation.
If it's difficult to choose between a score of 1 or 2, continue with medical history questions until you're confident in assigning a score. This is the only time you are allowed to go back and change a score. A score of 3 requires particular attention because it has an impact on how you'll score other scale items. In patients who appear to be in a coma and who score less than 3, you must attempt all items, but realistically, you will likely fall back on the predefined default values for coma patients. I will discuss these default values as we go along. They're also summarized in the scoring manual. You must choose a score, even if confronted with obstacles, for example, endotracheal tube, language barrier, orotracheal trauma, or bandages. Level of consciousness, item 1B, is based on the patient's answers to 2 specific questions, the month of the year and the patient's age. Would you please tell me your age? How old are you?
53.
Okay. And tell me what month it is right now.
February.
Okay.
For scale item 1B, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if both questions are answered correctly. Score a 1 if only one question is answered correctly. By definition, Patients unable to communicate because of endotracheal intubation, orotracheal trauma, severe dysarthria from any cause, a language barrier, or any other problem not secondary to aphasia are scored a 1. Score a 2 if neither question is answered correctly. A patient who scores a 3 on level of consciousness 1A must be scored a 2 on this scale item. Aphasic and stuporous patients who do not comprehend the questions will score a 2. If the patient is in a coma, a score of 2 would be assigned.
Because this is a standardized test and to ensure reproducibility of results, other measures of orientation, such as time of day, location, etc., are not asked as part of this examination. But a patient who cannot speak may be allowed to write the answer. If the patient has aphasia, you need to judge his responses to questions in light of the language impairment. Like always, only score the initial answer. If the patient first gives an incorrect answer and then corrects himself, it is nevertheless scored as an incorrect answer. Many patients will give you their date of birth when you ask for their age. This is scored as a wrong answer. There's no partial credit for answers that are close, like being off by a month. For the third part of item 1, or 1C, you ask the patient to perform 2 tasks. Before beginning this assessment, be sure to position the eyes and hands in a testable position, then ask the patient to do these actions. Close your eyes for me. Now open. Now make a fist with your hand. You may repeat the command once, but do not coach or encourage. To improve reproducibility, score what the patient does, not what you think they are capable of doing. In general, you should try to pantomime the command so the patient receives your verbal as well as visual input. Close your eyes and open them up. That's terrific. Take your left hand and make a fist. And now open it up. That's great.
For scale item 1C, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if both tasks are performed correctly. Score a 1 if one task is performed correctly. If the patient does not speak English, a friend or family member can be asked to translate.
Now ask her to close her eyes.
Cierra tus ojos. Ábrelos.
Ask her to take this hand and make a fist.
This hand.
This hand, make a fist.
Aprieta tu mano así. Haz tu mano así. Así.
Make a fist.
Score a 2 if neither task is performed correctly.
Now I want you to take your hand and I want you to make a fist. I want you to make a fist. I want you to close your eyes. Close your eyes.
A 2 is scored for patients with a comprehension deficit and who perform incorrectly.
Some subtleties here. Give credit if a real attempt is made but not completed simply due to weakness. Only score the first attempt. Again, do not coach or teach. By the time this scale item is tested, you will have already interacted sufficiently with the patient to judge whether or not the patient will actually comprehend your verbal commands. If you're dealing with patients with trauma, amputation, or other physical impediments, you'll need to substitute other one-step commands. The best gaze item, number 2 on the NIHSS stroke scale, tests voluntary horizontal eye movements. Disorders of vertical gaze, nystagmus, and skew deviation are not measured. First, look at the position of the eyes at rest. Make sure to note any spontaneous eye movements to the left or right. The next test is to move your finger or other target horizontally, asking the patient to track your finger from side to side by moving the eyes only. Make sure to keep asking the patient to follow the target. If the patient does not accurately follow your finger, a stronger test is needed. Use the oculocephalic maneuver, eye fixation, or tracking of the examiner's face. This is an exception to the rules of using the first observable response for scoring and not coaching the patient. In patients with poor attention spans, establish eye contact and move your face around the patient from side to side. This may clarify the presence of a partial gaze palsy. Now I'm going to test your gaze. I'd like you to look at my finger and follow it all the way over this way and all the way over that way.
For scale item 2, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if the tasks are performed correctly. If a patient has ocular rotary problems, such as a strabismus, but leaves the midline and attempts to look both right and left, the patient should be considered to have a normal response. Score a 1 for partial gaze palsy.
I want you to look at me look at me, look here. Now I want you to look over here. Look over here. All right. I'm going to help you out here a little bit so we can see your eyes. I want you to look over here. Now look over there. Okay?
If there is a conjugate deviation of the eyes that can be overcome by voluntary or reflexive activity, also score a 1. If the patient has an isolated cranial nerve paresis, such as an oculomotor or abducens palsy, also score a 1. Score a 2 when there is forced deviation or total gaze paresis not overcome by the oculocephalic maneuver.
I'm going to test your eye movements now. I want you to look at my hand. Can you look all the way over to your right? Look at my hand. And now look all the way over at me. Look here at me. All the way here at my hand. Good.
If there is a conjugate lateral deviation that is not overcome with reflexive movements, the score should be a 2.
The easiest way to score this item is to consider whether the eye movements are normal. If so, score a 0. If not, consider whether there is tonic deviation such that the eyes cannot be moved. If so, score a 2. Everything else would be scored a 1. Patients who scored a 3 on level of consciousness, item 1A, are in a coma and may have gaze palsy that can be overcome by moving the head. So in these cases, you should use the oculocephalic maneuver and score the result. To keep the testing conditions standard, do not do caloric testing. With aphasic patients, gaze is testable. Just like with confused patients, it helps to establish eye contact and move about the bed. And finally, patients with ocular trauma, bandages, pre-existing blindness, or other disorders of visual acuity or fields should be tested with reflexive movements and scored. This may mean removing the bandages. The third item in the NIHSS stroke scale tests the visual fields of both eyes. In the visual fields item, each eye is tested independently. Upper and lower quadrants are tested by confrontation. This means using finger movement, finger counting, or visual threat as appropriate. If a patient is unable to respond verbally, the examiner should check attention to responses to visual stimuli in all quadrants, or have the patient hold up the number of fingers seen. Make sure the patient is looking directly into your eyes during the testing. Tell the patient you will be testing peripheral vision and that you may move a finger to the right or a finger to the left or both. Then you test by asking the patient to count fingers in all 4 quadrants. Patients who scored a 3 on the level of consciousness, 1A, are tested using bilateral threat. Now the next thing I'm going to do is I want to test your vision. All right? So I'm going to help you cover your right eye.
Okay.
How many fingers do you see?
2,
Okay. And
2.
how many fingers do you see?
5,
Good. And how many fingers do you see?
1,
And how many up there?
1 or 2.
Now look at me. How many fingers down there?
1. 5. 1. 1.
For scale item number 3, this patient scored a 0. Let's look at how this scale item is scored. Score the item 0 if the upper and lower visual fields are normal. If the confused or language-impaired patient looks at the correct side of the moving finger, this is scored as normal. If a patient has severe monocular visual loss due to intrinsic eye disease and the visual fields in the other eye are normal, the examiner should score the visual fields as normal. Score a 1 only if you find a clear-cut asymmetry, including quadrantinopia or partial hemianopia. If there is an extinction, score the patient a 1.
And I want you to look at my nose and tell me how many fingers do you see out of the corner of your eye?
2, 1,
Okay, look right at my nose. Look at me. How many up there?
2,
Okay. Look right at my nose. Look at me.
1,
Okay.
2. The whole hand.
Look at me. Look at me. Look at me.
3,
Look right at my nose.
2,
All right. Now switch hands and cover your left eye for me. All right. Again, look at my nose.
1. The whole hand. 1, 2. Look like 3 or 4.
Okay. How about now?
1.
Look at my nose.
Score a 2 for a complete hemianopia.
Cover your right eye for me. When you see a finger, you tell me how many fingers you see.
1,
Good.
1, 1, 1,
All right, now I want you to switch eyes, and we'll try the same thing again.
1, 5,
Good.
5,
Good.
Score a 3 for blindness of any cause, including cortical blindness, which requires a positive diagnosis, and double simultaneous stimulation testing.
All right. Do you see my hand moving?
Yes,
How about now?
yes,
Okay. Do you see my hand moving now?
yes, I do.
How about now?
Yes, I do.
All right. As soon as my hand moves, you say now.
Ow.
Okay, one last thing. I want you to look right here at me. Look right here at me. Very good. If there is unilateral blindness or enucleation, visual fields in the remaining eye are scored. The result of this item will have an impact on the last scale item, extinction and inattention, and many of us check double simultaneous stimulation to visual input at this point. There is an arbitrary rule that if they extinguish, the visual field item is scored a 1, even if the fields are intact to confrontation. This rule helps even out the variations that occur when inexperienced examiners encounter neglect so severe that the patient appears to have a visual field cut. The next item on the scale is an assessment of facial palsy. To assess facial palsy, you ask or use pantomime to encourage the patient to show me your teeth. If the teeth aren't in, ask them, show me your gums. Open and close the eyes. You can say, squeeze your eyes shut as hard as you can. Raise the eyebrows or lift up your eyebrows as high as you can. The patient needs to look directly at you while performing the requested tasks. For the aphasic, poorly responsive, or non-comprehending patient, use a noxious stimulus. In this case, the symmetry of the grimace is the basis of scoring. I'm going to examine your face. So I want you to show me your teeth. Good. And now relax. Close your eyes real tight. Tighter, tighter. Very good. Now open your eyes and raise your eyebrows up. That's great.
For scale item 4, this patient scored a 1. Let's look at how this scale item is scored. Score the patient a 0 for normal symmetrical movement. Normal function must be clearly demonstrated. Orbital and forehead musculature movements are normal. Score a 1 for minor paralysis, such as a flattened nasal labial fold, or mild asymmetry while smiling. This is the proper score if function is less than clearly normal. Score a 2 if there is paralysis of the lower face. This is the appropriate score for clear-cut upper motor neuron facial palsy. Decreased spontaneous and forced facial movements are most prominent at the mouth.
Open your eyes. Look at me. Thank you. Can you show me your teeth? There we go.
Score a 3 when there is complete paralysis of the upper and lower face. This is the appropriate score for the obtunded or comatose patient, or one with unilateral lower motor neuron facial weakness.
Now ask her to do what I do, to show me her teeth. Show me your gums.
Enséñales así.
Good. Now close your eyes
Cierra tus ojos.
tightly. Tight.
Fuerte.
Fuerte. Tight. Tight.
Fuerte.
Good. And now raise the eyebrows up.
Abre los ojos.
And raise the eyebrows.
Levanta tu ceja. Tu ceja, levántala. La
Okay.
ceja.
Good. Good. The easiest way to score this challenging item is to first decide if the face is normal. If so, score a 0. If the face is not normal, ask yourself if there's a clear-cut asymmetry of the smile. If so, score a 2. All other findings, including subtle asymmetries of the nasolabial fold, are scored a 1. The score of 3 is reserved for the very unusual complete facial paralysis seen with some brainstem strokes. Remember to include using noxious stimuli to score the symmetry of grimace in poorly responsive or non-comprehending patients. Also, in the event of facial trauma, remove the bandages, tape, or other physical barriers that might obscure the face. Scale items 5 and 6 assess arm motor movement and leg motor movement. For motor arm and leg scoring, make sure to appropriately position the limb. Extend the arms 90 degrees if the patient is sitting, or 45 degrees if the patient is supine. Always test the leg in the supine position by extending the leg 30 degrees. You score drift if the arm falls before 10 seconds as you count down out loud, or if the leg falls before 5 seconds. Begin counting immediately at the release of the limb. You should also count down with your fingers in full view of the patient as you count out loud, so that the patient receives verbal and visual input. You can help the patient in this item by placing the limb in the desired start position. Watch for an initial dip of the limb when you release it. Only score abnormal if there's a downward drift after the dip. Each limb is tested in turn, beginning with the non-paretic arm. When testing the arms, the palms must be down. Do not test limbs simultaneously. Do not coach the patient. Only in the case of amputation or joint fusion at the shoulder or hip is this scale item not scored. But you need to make a written note of this. On some printed copies of the NIH stroke scale, you may be advised to score amputation as a 9 when scoring motor arm, motor leg, or ataxia, but don't use the 9s in calculating the total score. You'll have to use urgency in your voice or pantomime to encourage the aphasic patient. These patients may understand better what you are testing if you use the non-paretic limb first. If the patient has restricted limb function due to arthritis or non-stroke related limitations, you still need to give a score. Use your best judgment to differentiate between the effect of the stroke and any other cause. So I'm going to ask you to hold this arm up right here, straight out for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's terrific.
Okay.
Now let's try the other side. I'll hold it up, and when I let go, you keep it up for 10 seconds. Can we get it to there? Okay.
I don't know.
Let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay.
For scale item 5A, this patient scored a 0. For scale item 5B, the patient scored a 1. Let's look at how this scale item is scored. Score a 0 if there is no drift and the arm remains in position for a full 10 seconds after any initial dip. Score a 1 if the arm jerks or drifts down to an intermediate position without encountering support, such as a bed, before a full 10 seconds.
I want you to hold your arm up for 10 seconds. You ready?
Ready.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's terrific.
Score a 2 when there is some effort against gravity, but the arm cannot get to or maintain the proper position and drifts down to some support.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Score a 3 when there is no effort against gravity and the arm falls.
See if you can hold it up at all. Okay. And shrug that shoulder for me. Show me that shoulder move. There we go. All right.
Score a 4 if the patient is unable to make voluntary movements.
I'll hold it up for you. Right there. Now you hold it up. 1, 2, 3, 4, and it's hit the bed now. So what I'd like to know is, can you move it at all? To differentiate a score of 3 from 4, you have to encourage the patient and wait a second or two to observe movement in the paretic arm. Any movement at all, including small proximal movements, such as shoulder shrug or hip flexion, is enough to lower the score from 4 to 3. A patient who scores 3 on level of consciousness 1A is scored 4 on this item. Scale items 5 and 6 assess arm motor movement and leg motor movement. For motor arm and leg scoring, make sure to appropriately position the limb. Extend the arms 90 degrees if the patient is sitting, or 45 degrees if the patient is supine. Always test the leg in the supine position by extending the leg 30 degrees. You score drift if the arm falls before 10 seconds as you count down out loud, or if the leg falls before 5 seconds. Begin counting immediately at the release of the limb. You should also count down with your fingers in full view of the patient as you count out loud, so that the patient receives verbal and visual input. You can help the patient in this item by placing the limb in the desired start position. Watch for an initial dip of the limb when you release it. Only score abnormal if there's a downward drift after the dip. Each limb is tested in turn, beginning with the non-paretic arm. When testing the arms, the palms must be down. Do not test limbs simultaneously. Do not coach the patient. Only in the case of amputation or joint fusion at the shoulder or hip is this scale item not scored. But you need to make a written note of this. On some printed copies of the NIH stroke scale, you may be advised to score amputation as a 9 when scoring motor arm, motor leg, or ataxia, but don't use the 9s in calculating the total score. You'll have to use urgency in your voice or pantomime to encourage the aphasic patient. These patients may understand better what you are testing if you use the non-paretic limb first. If the patient has restricted limb function due to arthritis or non-stroke related limitations, you still need to give a score. Use your best judgment to differentiate between the effect of the stroke and any other cause. Now let's lift this one up, and when I let go, you hold it up for 1, 2, 3, 4, 5. Perfect. Go ahead and relax. Now we'll try the other side. I'll lift it and you keep it up after I let go, right there.
Okay.
1, 2, 3, 4, 5. That's great.
For scale item 6A, this patient scored a 0. For scale item 6B, the patient also scored a 0. Let's look at how this scale item is scored. Score a 0 if there is no drift and the leg holds the 30-degree position for a full 5 seconds. Score a 1 if there is drift and the leg falls by the end of the 5-second period, but does not hit a support such as a bed.
And you hold it for 1, 2, 3, 4, 5. Great.
Score a 2 when there is some effort against gravity, but the leg falls to the support within 5 seconds.
Tell her to hold it up.
Levántalo.
Up.
Así.
1, 2, 3, 4, 5.
Score a 3 when there is no effort against gravity and the leg falls to the support immediately, but the patient makes small movements such as hip flexion or adduction.
Now we'll hold this one up right there for 1. Okay, let's try it. Let's see you move it. All right, let's see you move that leg. Okay.
Score a 4 if the patient is unable to make voluntary movements.
Hold that leg up. Hold your leg up. Hold the leg up. 1, 2. Can you move it at all? Can you move that leg? Try moving that leg for me. Items 5 and 6 are the most reproducible of the scale and carry the most import in determining ultimate outcome. Please watch the limb very carefully and compare to a marker behind the patient to gauge whether the limb is drifting slightly. If it is not possible to test the patient on this scale item because of an amputation or hip or shoulder joint fusion or any other reason, the item is not scored. We discourage you from doing this in any but the most extreme cases, and the reason must be recorded on the form clearly. Patients scoring a 3 on level of consciousness 1A are scored 4. The test for limb ataxia, item 7, is an assessment for evidence of a unilateral cerebellar lesion. This test attempts to distinguish a clinically significant incoordination from general weakness. Perform the finger-nose-finger and heel-shin tests on both the right and left sides. Ask the patient to touch your finger with his index finger, then back to his nose, then repeat enough times to thoroughly test for ataxia. Then perform the test on the other side. Then test coordination in the leg. Instruct the patient to move one heel down and up the shin of the opposite leg. Give the same test on both the right and left sides of the body. Test the normal side first. Make sure the patient's eyes are open. In the event of a visual field defect, try to perform the test in the intact visual field. The next thing I'd like to do is check your coordination. Take your finger here and touch my finger. Now touch your nose. Now my finger, now your nose. Now my finger, now your nose. Good. Now on the other side, I don't know what we'll be able to do, but see if you can lift it and touch my finger.
I can't.
Can't get up that high. Okay. Let's see what happens with the legs. All right?
Okay.
I'm going to take your right leg. I want you to put your heel on your knee and run it down your shin. Let's see what happens. Can you bend the knee? Put your heel right there. And run it all the way down your shin. And back up again. That's great. Now relax. Now let me try the right leg. I'll lift it up, and you put the heel on your knee and slide it all the way down. And can you slide it back up?
I can't do it.
Okay, put it down and slide it down one last time. Very good.
Okay.
For scale item 7, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 if there is normal coordination. The movements should be well performed, smooth, accurate, and not clumsy. If there is significant weakness, assume ataxia is 0. Ataxia is scored only if present and out of proportion to weakness of the spastic limb. Ataxia is absent in the patient who cannot understand or is paralyzed, and so is scored a 0 on this item. Score a 1 if ataxia, dysmetria, or dysenergia is present in one limb.
I want you to take the heel, put it on your knee, and run it down your shin. Just take that heel and put it right there, run it down your shin, and back up. And now do the same thing on the other side. Put the heel on the knee, and run it all the way down, and back up. And run it all the way down to the end this time, and back up. And that's terrific. Relax.
Score a 2 if ataxia is present in two limbs, both arms, both legs, or an arm and a leg on the same side of the body. Also score a 2 if you observe dysmetria or dysenergia in both the arm and the leg on one side, or if there are bilateral signs.
So take this finger right here and touch my finger. Now touch your nose. Now my finger. Now your nose. Now my finger. Good. Let's try that on the other side. Touch my finger as quick as you can, and now your nose. Back and forth, back and forth, back and forth, back and forth. Yeah. There we go. Okay. I want you to take your right leg, put the heel on your knee. So lift this heel up, put it on your knee there, and just run it straight down your shin. Straight down the shin and back up. Good, good. Now switch sides and put the left heel on the knee there. Run it all the way down and back up. That's good. It's important to remember that this item is scored a 1 or a 2 only if ataxia is present and out of proportion to weakness. In the case of amputation or joint fusion, you may mark the item untestable, but make sure to write the reason on the form. Patients scoring a 3 on level of consciousness 1A are scored only if ataxia is present. Otherwise, give a 0. You test sensory perception with a series of pin pricks. Withdrawal from noxious stimulus is used in the obtunded or aphasic patient. Do not use any object other than a safety or seamstress pin. No paper clips, broken sticks, or ballpoint pens. Examine the patient with a pin in the proximal portions of all 4 limbs and ask if the patient feels the stimulus. The patient's eyes do not need to be closed. Ask the patient if there is any asymmetry between the right and left sides. Asking if the patient feels sharp or dull only begs for confusion and misinterpretation. To optimize reproducibility, ask the patient only to compare the 2 sides and tell you if there is a difference. In confused, aphasic, or obtunded patients, observe for symmetry of grimace in response to the noxious stimulus. Only sensation loss attributed to stroke is scored. Test as many body areas, arms, legs, trunk, and face, as needed to accurately assess for hemisensory loss. Do not test limb extremities like hands or feet when testing sensation, since the response may be confounded by an unrelated neuropathy. Unless absolutely necessary, do not test through clothing. I'll touch you on the right or the left, and you tell me if they're the same or if one side's sharper. Starting with your face, right, left, which one's sharper? Or are they the same?
About the same.
About the same, all right. Let's try your hands, right, left, which one's sharper, or are they the same?
Dollar.
Duller on the right, okay.
Dollar on the right.
Let's try your legs, which one's sharper, or are they the same?
One's dollar on the right.
For scale item number 8, this patient scored a 1. Let's look at how this scale item is scored. Score a 0 when there is no evidence of sensory loss. Score a 1 for mild or moderate loss.
I'm going to test how well you feel this pin now. I want you to tell me if the right side is sharper, the left side, or if they're the same.
Okay.
Starting with your face. Which side is sharper?
Left.
Which side is sharper?
Left.
Left. Arms, which side
About
is sharper?
the same.
About the same? Okay. We'll go to the legs.
The left side is sharper.
Left side is sharper.
Score a 2 when evidence confirms severe loss. Only give a 2 when a severe or total loss of sensation can be clearly demonstrated. Patients with brainstem stroke demonstrating bilateral loss of sensation also score a 2.
Now I'd like to see if you can feel any sensation. I'm going to touch you with this pin. Can you tell me anything about that? Can you feel that? And I can't tell, so I'm going to try something else. I'd like you to tell me if you feel this, if you feel that squeeze. All right? Now how about on this side? Can you feel the squeeze on this side? Okay, and I can see you pulling back on that one. This item is never marked not testable. You should test stuporous or aphasic patients with vigorous noxious stimuli, such as nail bed pressure, and then decide between a 1 or 0 based on whether any response appears. Patients who score 3 on level of consciousness 1A will automatically score a 2 on the sensory item. For item 9, best language, we score the patient's language skills. Listen for this item as you perform the entire stroke scale examination. By this time, you'll know a lot about the patient's ability to comprehend language, and you may be able to score the item. However, it's almost always wise to confirm your impressions developed to this point in the exam using the formal testing tools provided. This scale item is an exception to the rule of scoring only the first impressions. We encourage but do not coach or stimulate the patient's best performance. The patient's language is tested by having the patient examine the cookie jar picture and the standard naming card and by reading a series of sentences. The objects and sentences are provided with the stroke scale exam. Always determine if the patient wears glasses. If so, they will be needed for the exam. Give the patient adequate time to identify the objects on the object card. Ask the patient to name each item on the card. Ask the patient to describe the meaning and action depicted on the cookie jar picture. Encourage, but do not coach the patient to be as complete as possible. Ask the patient to read all the phrases on the sentence card. The assessment is based on your overall sense of the patient's language as well as on their responses on these tests. I'd like you to put on your reading glasses here.
Okay.
All right. I'm going to show you a card. I want you to tell me what you see in that picture.
Socket,
Mm-hmm.
hostess, and going outside,
Mm-hmm.
just washing, and falling down.
Falling down. Good. Now I have some pictures. Can you tell me what that is right there?
Glove,
Okay. And that right there?
feather,
Good. And this one?
hammock,
Good. And this one?
chair,
Mm-hmm. And this one?
cactus,
Uh-huh.
yeah.
And this one?
key.
Good. That's great. Can you read these sentences for me?
You know how down to earth I got home from work.
Mm-hmm.
Near the table in the dining room,
Mm-hmm.
they heard him speak on the radio last night.
For scale item 9, this patient scored a 1. Let's look at how this scale item is scored. Score a 0 if there is no aphasia. Score a 1 for mild to moderate aphasia, evidenced by some obvious loss of fluency or facility of comprehension, but no significant limitation on ideas expressed or form of reductions. A limited reduction will still allow you, as the examiner, to identify the picture or naming card content from the patient's responses.
What I'm going to do is give you this picture here, and I'd like you to tell me what you see in that picture. Describe to me what you see there.
Well, boy has getting cookie jar. Now he's falling on the stool.
Very good. Do you see anything else?
Sloppy people. Okay.
Yeah.
Like that.
What else do you see?
The lady has wants to dishes and overflow the sink.
Excellent. Okay. Now what I'd like you to do, I have another picture, and I'd like you to take a look at this and tell me what that object is right there. What is that right there? Can you tell me the name of that object?
Globe.
Excellent. How about this one?
Key.
How about
Chair. Cut. I cannot pronounce.
Okay. How about
Cat. Cuts.
good. All right. How about this one here?
Feather.
And this one here?
Hammock.
Okay.
Score a 2 for severe aphasia when all the patient's expressions are fragmentary or when you cannot identify card content from the patient's response.
Ask her if there's anything in that picture she can tell us.
Ma, mira el dibujo y ¿qué están haciendo ellos? A ver, trata de decir qué es lo que están haciendo. No, aquí. Mira el dibujo. ¿Qué está haciendo ella?
Tell you what, let's try a different one and see. What I'd like her to do is look at the card and tell us if she can point to the chair.
¿Puedes apuntar dónde está la silla? La silla, mira el dibujo. ¿Dónde está la silla? Toca la silla con tu mano.
Okay.
Score a 3 if mute for any reason or for global aphasia, or if no usable speech or auditory comprehension is demonstrated. The examiner must choose a score of 3 for the patient with a stupor or limited cooperation.
Would you take a look at this card? Is there anything that you can tell me about it? I'll hold it where you can see it. Can you speak at all about that card? Let me try one more thing. I have a few pictures here. Can you tell me what this object is on the picture card? The intubated patient should be asked to write down responses to the examiner's questions. If a patient's visual loss interferes with testing this item, you may ask the patient to identify objects placed in the hand. You'll also need to elicit samples of speech. On the naming card test, it is very common for visually impaired patients to identify the feather as a leaf and the glove as a hand. Also, in some parts of the country, the cactus picture will be identified as animals in profile, such as squirrels. I usually score these responses as correct. Hammocks are not common outside of the Americas, so patients from other cultural groups may not know the term. Patients scoring a 3 on level of consciousness 1A are scored 3 on this scale item. Mute patients may have some cause other than aphasia for not speaking, but to optimize scoring reliability, you always give the mute patient a 3. Remember, score what you see, not what you think the patient can do. In item 10, dysarthria, we test the patient's articulation and clarity of speech. It's important that you don't explain the purpose of this exam. Ask the patient to read or repeat the words from the word card provided with the stroke scale. So I'd like you to pronounce these words for me.
Mama, tip top, 50-50, stinks, huckleberry, baseball player.
Okay.
For scale item number 10, this patient scored a 1. Let's look at how this scale item is scored. Score a 0 for patients with normal speech who read all words without slurring. Score a 1 for patients with mild to moderate speech defects and some slurring, but who can be understood.
Would you read those words for me, please?
Mama.
Mm-hmm.
Tip top.
Mm-hmm.
50-50.
Mm-hmm.
Thanks.
Mm-hmm.
Huckleberry.
Good.
Baseball player.
All right. Very good.
A score of 2 is reserved for the patient who cannot be understood in any meaningful way or who is mute.
Would you ask her to say mama?
Ujú.
Ask her to say mama.
Mamá. Di mamá. Ma, ma. Ma, ma.
Okay. An unresponsive patient receives a score of 2 on this item. Patients scoring a 3 on level of consciousness 1A are scored 2 on this scale item. The item is untestable only if the patient is intubated or has other physical barriers to producing speech. Remember to clearly document and explain this problem on the form. Aphasic patients and patients who do not read may be scored based on listening to the speech they do produce or by asking them to repeat the words after you read them out loud. In some cases, the speech may be hard to understand due to dental or other non-neurological causes. Nevertheless, score the item a 1 to optimize reliability among examiners that might have varying degrees of experience. We come now to the last scale item, which tests for neglect or inattention. You may have enough information by the time you reach this point in the exam to make a judgment, but if abnormalities are not clear, the presence of neglect is examined by the patient's response to double simultaneous stimulation. Unless there is obvious neglect or anosognosia, it is wise to double check. First, ask the patient to close their eyes. Alternately touch the patient's left or right side, and ask the patient which side is being touched. After the patient responds consistently, then touch the patient on both sides at once. The patient without neglect will identify sensation on both sides. Patients with cortical impairment may extinguish one side. That is, they will only perceive sensation on one side. Since neglect is scored only if present, the item is never untestable. Now, the last thing I'd like to do is tap you on the right, left, or both. You tell me which it is, all right? Close your eyes. We'll start with your face. Right, left, or both?
Okay.
Can you say if it was left, right, or both?
Okay, right.
You know what might be easier for you is if you take your finger and point to the side that I'm touching. Okay? Point to the side that I'm touching. Good.
Right.
All right.
Left.
Good.
Both.
Excellent. Now, you're able to pronounce it now, so let me try the hands. You tell me if this is right, left, or both.
Right.
Good. Okay.
Left.
Wait for me to touch it.
Both. Both. Left. Right. Both.
Beautiful. Keep your eyes closed, and I'm going to tap your legs.
Right. Left. Both. Left. Both.
I'd like to do the same thing now in your vision. You can point to the finger that wiggles. It'll either be right, left, or both.
Right. Left. Right. Both. Both.
Good.
For scale item number 11, this patient scored a 0. Let's look at how this scale item is scored. Score a 0 for the absence of neglect. If the patient has a severe visual loss, preventing visual double simultaneous stimulation, and the cutaneous stimuli are normal, the score is normal. If the patient has aphasia and cutaneous stimuli are normal, the score is normal. Score a 1 for inattention to only one modality, visual, tactile, auditory, or spatial. If the patient does not extinguish but shows other well-developed evidence of neglect, score a 1.
I want you to tell me if you see a finger wiggling on the right side, left side, or both sides? Where's that?
That's left. Right. 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 Left. Right. Right.
Okay.
A 2 is scored for profound hemi-inattention or extinction to more than one modality. Score a 2 if one side extinguishes to both visual and tactile stimuli using double simultaneous stimulation. Score a 2 if there is inattention to more than one category: visual, tactile, auditory, or spatial inattention. A patient with a score of 3 on level of consciousness 1A is automatically scored a 2.
People need to be trained. They need to understand the rules. As I said, having the reference materials when you're using the scale is, I think, very, very important, and just being consistent.
Don't coach the patient. Don't go back and rethink a particular assessment. Because patients can be coached, and that, in fact, changes the physical sign itself.
Another thing that happens is that as neurologists or as physicians, we think we know what the patient should do. And we very often will tend to want to code what we think they should do as opposed to what they actually do. When you're using a scale like this, it's, again, very important to follow the rules. And you don't coach the patient where you're not supposed to coach them, and you don't rate what you think they want to do or what you think they can do. You rate what they actually do.
Ataxia. There's some language items, dysarthria, things that you need to have a reasonable amount of experience with this patient population to make good decisions about. They're always the ones that people tend to screw up and score wrong, but distinguishing an ataxic patient from a patient who has motor weakness takes a little of experience and insight, and you need a good mentor to help you get through that decision-making process and people to teach you that have that insight.
I think the most difficult item to score on the stroke scale is the visual field score, especially in patients that have non-dominant hemisphere strokes. Those patients tend to have neglect, and when they're neglectful, it can be very difficult to tell apart the neglect from an actual visual field deficit.
I think the other item is facial weakness and facial asymmetry. And sometimes when people have real subtle changes in their lower face, saying, is that something that's really there or not? That's also a hard judgment.
When it comes to doing the facial observation, just really call it as it is, which is no different to the advice that has been given. Don't try and interpret it on the basis of whether or not you've seen weakness in the arm or you're expecting a hemiplegia. Again, just have a prime response that you've become used to in terms of assessing facial asymmetry.
Well, I think it's important when you address the motor part of the scale, just like any part of the scale, that you use the patient's first response. And it's not a summary of responses over, let's say, 5 or 10 minutes. And that's a mistake that I think some people can do doing the scale.
Any wavering, if the patient's arm is up and it falls down and then they bring it back up again, that's abnormal. To score a normal on the arm function, they have to hold the arm in the same place and not let it drift down at any time.
I actually think one of the really neatest parts of the scale was the part of the scale which looked at motor assessment. Before, there was all these different ways of trying to see how weak a person was. And all of these scales had a lot of, I guess, subjective feel to them. So the idea of having somebody hold up their arm and just usually and taking 10 seconds for an arm or 5 seconds for a leg and counting and saying, did it stay rock solid? Did it drift? Did it drift and hit the bed? Or did it not move at all? That was such a quantifiable way of looking at the motor function that I think that was one of the major advances, I think, in the scale and why the scale works so well.
Well, the most challenging aspect in my mind is the ataxia question. But there are some other things that are somewhat more difficult to do. They're looking for inattention, sorting out a homonymous hemianopia from loss of vision to one side versus some neglect, trying to decide whether it's neglect alone, whether it's visual field defect alone, or whether it's both. That can be problematic. Deciding how bad the weakness is. Is it a 3 or a 4? That's points. That's the sort of judgment call that every physician just has to make.
The thing to remember with the ataxia score is that if they're real weak, assume that the ataxia score is 0. If they got their arm or leg can be held up pretty well with just a minimal drift, but they're all over the map when they're trying to move their arm or leg when they do the finger to nose testing, that's probably ataxia. And the ataxia is really, is it present or not? And then is it present in one limb or 2 limbs? And that's how you score it. So if you keep that in mind, remember that when they're very weak or they're paralyzed, it's always 0 for the ataxia score. What it tries to reflect is that there's some people with stroke that damage a part of the brain where the strength is okay, but the coordination is very affected. And this is particularly true in strokes that occur in the brainstem or the cerebellum part of the brains.
The sensory item is easy to score. It's fairly straightforward. The patients that are most difficult to score are those that have non-dominant hemisphere strokes and have neglect. These patients may be neglectful of your attempts to score the sensory item, but in general, it's a very straightforward exam with pinprick and light touch.
It's difficult to be sure just how profound the sensory loss is or whether they even have sensory loss. And again, if you're not sure the patient has sensory loss, then don't give them the sensory loss. You should only score loss of sensation if you can clearly demonstrate that they have it.
Somebody that comes in with sensory loss in their legs from neuropathy, you don't want to count that towards the stroke. But if they have sensory loss on top of the neuropathy, you do.
Aphasia is a difficult thing to test, not so much because we don't know as physicians what an aphasia is, but it takes a longer time to go through the entire aphasia battery, and then it's a little bit subjective as to is it a mild, moderate, or severe aphasia. Obviously, if the patient has global inability to comprehend or to speak, so-called global aphasia, that's a very severe aphasia. I score a mild aphasia if the patient's still able to have functional speech. They're able to get their thoughts and meaning across and able to understand most things.
There are several ways that you can test aphasia. You start to recognize the patient has aphasia when you first meet them. And you start talking to them, and you're not getting a history as to what's happened. Right away, we know there's a language impairment. Now, we have formal things that we have asked them to do, the reading, the naming the items, etc. Very quickly, you recognize how bad the aphasia is.
Now, dysarthria is another one because there are many cultural things about slurred speech. It's hard sometimes to make a judgment on, is this someone's normal speech or is this an impaired form of speech? And sometimes you just look over to the family to see, do they always talk like this? And you know, or is this an impaired, slurred speech?
Dysarthria is generally quite easy to score. You should keep in mind that you will be scoring dysarthria, so pay attention to your entire interaction with the patient. Using the words and the pictures that are supplied in the NIH stroke scale will clearly help you distinguish dysarthria from aphasia.
Dysarthria is a very difficult thing to score because it's not difficult in the patient who has normal language function. But in the aphasic patient, it's difficult to know when somebody's not talking very well. Are they dysarthric or is this all aphasia? And generally, if the patient is mute, I give them a 2 for the dysarthria scale. If they're able to talk and make some language function, then I have to make my best assessment as to whether they have some element of dysarthria or not. And usually I wind up giving most aphasic patients a 1 for the dysarthria scale.
The NIH stroke scale is a very useful tool for emergency physicians. The greatest hurdle is to become trained in it and to do it consistently. We recognize that emergency physicians have great time constraints, but the NIH stroke scale provides significant benefit and can be done in less than 7 minutes with the patient.
There are about 10,000 neurologists in practice in the United States, but over 600,000 strokes. The large majority of patients with stroke are cared for by non-neurologists.
And I think here is the really big value for the stroke scale, that it can be done in the primary care setting by healthcare professionals that are not necessarily trained neurologists can make a very quick assessment of their patient.
I think nurses need to be empowered to include this into their practice. You realize that not so long ago, the care of a stroke patient, nobody cared about what happened to the brain because we were basically just there to prevent pneumonia and urinary tract infections and make sure they didn't get bed sores. The reality is I would rather be treating somebody's brain. I would want to know that some of my interventions and my assessments helped allow this patient to go home and be independent.
If anything, the nurses and physician's assistants may actually do a little bit better than neurologists. Again, neurologists very often want to score how they think the patient should do, whereas people such as nurses very often will want to follow the protocol exactly.
How do you feel today?
Fine.
And do you have any pain?
No pain.
No pain. Good. Can you tell me what's the month?
The second month. The date, I don't know what the date is.
Okay. Tell me, how old are you?
I'm 58.
Can you show me your left fist? Good. Can you make it real close? Open it up. Good job. Can you close your eyes real tight? Open your eyes real wide. Good job. Can you go all the way that side? Good. All the way this side. Do you see my finger wiggling?
No.
How about now?
No. No.
Okay. Look at my finger again.
No. No. No.
Okay, good.
Yeah. No. No. No.
Okay. Look at my nose.
No. No. No.
Okay. Show me your teeth. Good job. Now put it down. Close your eyes as tight as you can. Good. Now open your eyes. Good. Now raise your eyebrow real wide. Okay. All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. 1, 2, 3, 4, 5. Good. 1, 2, 3, 4, 5. Okay. Okay. Do it back and forth. Good. Good job. Try to see if you can do it.
Okay.
Do it slowly. Run it straight down. Do you feel it?
Yeah.
Do you feel it this side?
Yeah.
Do you feel the same here and
Yeah.
here? You feel the same?
Same thing.
Good. How about here?
Yeah.
You
Yeah.
feel the same?
Yeah.
Okay. And put your hand here for me.
Yeah.
Do you feel the same?
Yeah.
Okay.
Yeah. Yeah.
You feel the same?
Yeah.
Okay. Good. What happens in this picture?
Putting the cookies up there.
Mm-hmm.
She wiping it, drying the plate.
Okay. Okay. And what else?
The water running over in the sink.
Can you just tell me what does this names? What is this?
Chair.
Good. What is this?
Key.
How about this one?
Glove.
How about this one?
Forget the name of it.
Okay. How about this one?
That's
This one. You don't remember the name? How about this one? These things. No, you don't know. You can read this sentence.
You know
for me.
how.
Good. How about this one?
Down to it. I got home from work. Never take me in the dining room.
Okay.
I heard him speak on the radio last night.
Okay.
Miami.
Okay.
Tip top.
Okay. How about this one?
Fifth.
Okay.
Thanks.
All right.
Huckleberry.
Okay.
Baseball player.
Okay. Tell me which side I touch you.
Right side. Right side. Left side. Both sides.
Okay. Which side I touch you?
Left side. Left side. Right side. Both sides.
Which side?
Right side. Left side. Both sides.
Okay.
Right side. Left side. Left side. Both sides. Right side. Right side. Left side. Both sides.